Welcome to a breast cancer educational town hall hosted by Mayo Clinic and the Coalition of Blacks Against Breast Cancer. I'm Denise Johnson, Community Relations Coordinator for the Center of Health Equity and Community Engagement Research here at Mayo. To start the program, I just want to share with you again that Black women are 41% higher risk of death from breast cancer. Among women under age 50, the disparity is even greater. So we're here to talk about how we can change those numbers. With us today on the panel is Dr. Michele Halyard, radiation oncologist and Dean of Mayo Clinic Alex School of Medicine, and co-founder of the Coalition of Blacks Against Cancer. We also have Dr. Sarah James, radiation oncologist and assistant professor and consultant in radiation department, as well as Dr. Donald Northfelt, medical oncologist and assistant director of the Center for Health Equity and Community Research. A very special guest, Panita Pritchard, who has been diagnosed with triple negative breast cancer back in 2019. She is cancer-free now, and she is going to share her journey and her involvement with the coalition. Welcome everyone again. You do have opportunity to provide your questions in the Q&A and in the chat. And towards the end of the program, after the presentations, we will address the questions. I'd like to start first with Dr. Halyard.
Thank you, Denise, and welcome everybody today. We're glad that you took the time to join us and hopefully learn something that will help your knowledge about breast health and breast cancer. And we encourage you also to share this information with others who may not be able to join. So the first thing that I'll say that it is important regarding whether it's regarding learning about breast cancer or other diseases, to really know your body. And I think nowhere is this more important for women than really understanding your own breast health. So even though mammogram is a gold standard for diagnosing breast cancer, we know that early detection is really the key towards surviving breast cancer. And we do have millions of survivors out there, as Panita is a prime example. But understanding what's normal for your body is really of utmost importance. So there's certain breast changes that should be reported to a healthcare provider if you note them. So the first thing I always tell patients is that you need to really examine your breast at least monthly. You really need to look at them in the mirror and determine if has there been anything that's changed. You want to look to see if there's any scaliness or changing of the nipple or the other skin of the breast or a rash-like appearance. If your nipples have always stuck out, but now one is pulling in, that could be a sign that something's wrong and should be investigated. If you have a sudden nipple discharge that is not normal for you, that should be investigated. And many times people think that cancer does not cause pain. And usually breast cancer is detected at a size or a stage where it's not painful, but sometimes an area where you've developed new pain that doesn't go away can be a sign that something's wrong. Now, obviously, when people have breast cysts that are benign, particularly younger women, sometimes you can get pain in the breast. But if you notice something that is just different, please have it investigated. So I want you to pick a day of the month to look in the mirror, look at your breast, and see if anything has changed. In addition to the things that I've talked about, do you see any change in the color of the breast? Has it become redder or perhaps purplish in color? Has the skin looked different, such as more like an orange peel? Is there swelling of one breast? Now, obviously, both breasts can swell when you're having your period. That's normal. But if you see something that just looks abnormal, please check it out with a healthcare provider. It's also important to feel your breasts and know what they feel like. Now, for many women, they say, "Oh, I'm not sure what my breast should feel like. It's lumpy. I'm not sure what's abnormal." And what I always tell women is just to familiarize yourself with what your breast feels like, and then you can get a baseline of what's normal for you. Sometime your breasts change around the time of your period, and so you may want to do that breast exam a couple of weeks after your period ends or kind of in the middle of the cycle. But the things that you're looking for are any changes in areas that are different than what has occurred before. So I think many of us have in our mind that breast cancer just feels like a hard knot or a lump, but it doesn't have to feel like that. Some women describe their breast cancer, if they can feel it, as a thickening. Some feel that it is like a hard lump or not, but it doesn't necessarily have to be. You're looking for anything that really feels different. It's important to examine all parts of the breast, so make sure you don't skip an area. And it's also important to know that the breast extends up into the armpit area. The tail of the breast goes up toward the armpit. So don't forget to look at that and feel that area too. So we've talked about feeling the breasts. Are you feeling any particular warmth in the breast? So in addition to sometimes seeing swelling, you can feel warmth in the breast, and that's important to know, particularly if it's an isolated area. In addition, looking for any or feeling any changes or puckering of the skin. If you have a question about anything, please contact your healthcare provider, have them do a breast exam, and tell you whether they feel that there's any concern or not. But if you know that something is definitely different, definitely changed, you can really press to have it evaluated because you have to be your own health advocate. So now let's talk about mammograms. Mammograms are x-rays that show us the interior of the breast. So we can only see with our eyes what the breast look like on the outside, but a mammogram is an x-ray of the breast that shows us what the breast looks like internally. And importantly, it shows us, have there been any changes or are there any changes in the breast that would warrant a biopsy to determine if there's cancer or not. Now, many women go through mammograms every month and they never have anything wrong. But sometimes we can pick things up on mammogram that are not apparent on physical exam, that are early breast cancers or even pre-breast cancers. And mammogram is the gold standard X-ray for diagnosing breast cancer. Some women don't know what a mammogram is like, and you might hear stories that it hurts, that it's unpleasant. I'll say it's not necessarily the most favorite thing for women to have done. However, what happens is they put your breast on a little plate that compresses it, so that a film plate, so we can take an X-ray, and there's a pressure for about 30 seconds at a time. And so even though there's a bit of pressure, it's not something that you can't tolerate. It's important to understand when you should start screening with mammograms. And a screening mammogram is one where you don't have any signs or symptoms and you're going for a check. Now, you might read different types of recommendations out there about how frequently you should get a mammogram, but I like to follow the recommendations by the American Cancer Society, and Mayo Clinic, which suggest at a minimum, you should really start screening probably at about age 40 to maybe 45, particularly if you have a family history, in which case you may need to start younger. But at 40, you need to start having the conversation with your healthcare provider about should you be getting a mammogram, particularly Black women, because we typically have a type of breast cancer called triple negative breast cancer that can occur at earlier ages or younger ages. So 40 to 45 is really kind of a personal choice. By age 45, you should start to be having annual mammograms, and at least have those annual mammograms up through age 55. Most of the screening recommendations say that beyond about 55, you can go up to every 2 years. I strongly recommend for Black women that you do it annually, but you should talk about that with your healthcare provider. There's also some discussion about when should you stop screening. There's a guideline called the U.S. Preventative Task Force that says there's insufficient evidence to recommend mammogram screening above age 75. However, I know many 75-year-olds who are in great health, and their family history would suggest that they're destined to live a long time. And so the recommendations by the American Cancer Society is to screen as long as your life expectancy is at least 10 years. So again, it's a good discussion to have with your healthcare provider. So takeaways are: know what your breast feels like, know what it looks like, pick a time of the month to really examine your breast. And if you're still having periods, probably pick a time kind of mid-cycle so you don't have some of the menstrual related changes. If you're postmenopausal, pick a date, something that you can remember. And also make sure that you're getting your mammograms on a regular basis, talking with your healthcare provider about how frequently that should be done. And I would say one other thing, that if you have a mammogram, understand what the results are. You need to read the report. Everybody's going to be sent a letter about the results of their mammogram. If there is something to follow up with, please follow up. Don't stick your head in the sand and say, I really don't want to know. Chances are it could be nothing. However, if it is something, early diagnosis and early detection is the key. So now I'll turn it over to my colleague, Dr. James, to give you some more information. Dr. James?
Thank you. So I want to talk just a very few minutes about local therapy for breast cancer, so particularly surgery and radiation. So the initial surgeries for breast cancer were radical mastectomies. So these were surgeries where there was removal of all the breast tissue, the underlying muscle, the skin, and then many lymph nodes in the armpit area. And of course, those surgeries had a lot of morbidity associated with them, as well as disfigurement from those surgeries. So naturally, there was a push to see if you could do less aggressive surgery, especially for patients that were having earlier disease, and get good outcomes. And so that was what happened is that surgeries improved and were less aggressive, and then looked at doing a breast conservation type surgery, which is oftentimes referred to as a lumpectomy procedure. And with that surgery, just the tumor is resected in the breast, along with a good margin around that tumor. And so when that was initially implemented, there was a head-to-head comparison of patients that were receiving mastectomy and the lumpectomy procedure. And patients with just the lumpectomy surgery had a higher risk of recurrence with just those surgeries alone. And then we started to utilize radiation in the case of the less aggressive surgeries. And with that head-to-head comparison, we saw equivalent outcomes as far as keeping the cancer controlled and a lower risk of recurrence of disease. So that was game changing, in that now many women could elect to conserve their breast and keep their breast after a diagnosis of breast cancer. And I am certainly pleased to practice now in the modern era, where when I first started training, it was commonplace in the standard of care for all breast cancer patients to get at least 25 daily treatments or 5 weeks of daily radiation treatment. And then we had evidence that we could do that in as few as 16 treatments, then down to 15 treatments. And today, it's not uncommon for us to be able to appropriately treat many, many women with just 5 days of radiation to the breast. And if radiation is just recommended to the lumpectomy site alone, it can be given in as little as 3 treatments. We're still doing a lot of clinical trials and getting data for shortening treatments for people that need radiation after mastectomy. But here we very commonly treat in just 3 weeks or 15 treatments in that scenario, and are looking to see whether or not we can shorten that treatment course even further to 5 treatments or so in that situation. So all of this progress and innovation comes from clinical trials. But unfortunately, we know that not many Black women enroll and participate in clinical trials. And that is problematic in several ways. So I would say first, there is the issue of not getting the benefit of the clinical trial itself, or the benefit that you get as a participant. So we know that people in general do very well on clinical trials because you're getting the highest quality care that's very well monitored. It's a very rigorously performed evaluation of these treatments. And so there's benefit to yourself being a participant in these trials. Secondarily, there is then the benefit to those that come behind you with a similar diagnosis, that they get the benefit of your participation to understand the better treatments and the ways that we can innovate these treatments. And then lastly, I would say that then there is the benefit in getting access for these treatments. So to get coverage for these treatments by insurance carriers, and for government to then push to have these treatments covered and accessible for all women. So I strongly encourage you that if you have the opportunity to participate in clinical studies or clinical trials, that you consider enrolling and participating. And if you have a reason for not participating, if you decline, I also strongly encourage you to share that reason with your treatment team or with the research team. It's our responsibility as a part of the healthcare system to identify barriers and to try to remove them as possible for patients. And if you speak up and say something like, hey, I can't come back to the clinic for just that single blood draw, then sometimes you can be told that that may not be necessary in your case, or an exception can be made, or they can make a revision to that study, and then it can be more accessible to more patients. And so all of that information is vital for us to use in order to make clinical studies much more widely available and much more effective. And what we all want to do is to make progress in the treatment of breast cancer. And so now I'll turn it over to my colleague, Dr. Northfelt.
Thank you, Dr. James. I'm a medical oncologist, and you might ask yourself, why is a medical oncologist appearing on this panel? So let me explain. The first thing I have to say is that most women diagnosed with breast cancer in 2022 will be cured of their cancer. And I still find it saddening and surprising when I see a new patient for the first time and she imagines that her life is over because she's been diagnosed with breast cancer. That is almost never true. In the vast majority of cases, a woman with a new diagnosis of breast cancer in 2022 will be cured of her disease. She'll have effective surgery. She'll see Dr. Halyard or Dr. James and have effective postoperative radiation. And as a result of that local therapy to the breast and armpit, that woman will be cured. So again, why is a medical oncologist on this panel if that's the expectation? Well, we know that not everybody is cured. Occasionally, women who've gone through curative treatment relapse. And they may relapse in their lungs or their liver or their skeleton or some other part of their body. We don't want that to happen. We want that cure that the surgeon and the radiation oncologist have provided to last. So the medical oncologist has tools that we can use to increase the likelihood that a person has been cured. In other words, to increase the likelihood that the cancer will not come back in the lungs or the liver or the skeleton. So the medical oncologist provides medical therapies. That could be anti-estrogen medicine, it could be chemotherapy or others that will reduce the risk of a relapse of the cancer once curative treatment has been provided. So I was asked to mention a few examples of how medical oncologists add to the likelihood that a woman will be cured of her breast cancer. So I'm going to talk about three different scenarios. In one scenario, a woman has been diagnosed with a breast cancer that's driven by estrogen in her body. And that's the majority of breast cancers that we see. Estrogen is responsible for driving the growth and spread of the breast cancer. We're able to use an anti-estrogen medicine, that would be a pill that I would prescribe, that a woman takes once a day, typically for 5 years. And that can dramatically reduce the risk for relapse of estrogen receptor expressing or estrogen driven breast cancer. What we've learned recently is that there are some women who have locally advanced breast cancers, big tumors in the breast or many lymph nodes in the armpit that are involved with cancer. Even though they've had curative surgery and radiation, their risk for relapse remains higher than we would like because their cancer was so advanced when it was first identified. So those women, in addition to receiving anti-estrogen medicine to reduce their relapse risk, can now receive an additional medicine, a booster medicine, that has been proven to reduce relapse risk even further. This came about, our understanding of this came about through participation that women had in a clinical trial in which this booster medicine was added to standard anti-estrogen medicine to see whether it would lead to better outcomes. And in fact, it did. So now we know, as a result of this clinical trial, that in addition to anti-estrogen medicine to reduce relapse risk, if we add the booster medicine, it adds additional protection against a relapse of estrogen receptor expressing breast cancer. I want to talk about another form of breast cancer. That's the type that's driven by a genetic difference. Some women are born with a genetic difference. They have what's called BRCA mutation, and that predisposes them to developing breast cancer. It's a mutation that they're born with that predisposes them to developing breast cancer. a specific medication was developed to treat that type of breast cancer. And it was tested in a clinical trial. And it's very similar to the story I told a moment ago. In this clinical trial, women with BRCA mutation with breast cancer had their curative surgery, had their curative radiation treatments. And then they were placed on this special medicine that was devised to reduce the risk of relapse in women with BRCA mutation. And it worked spectacularly to reduce relapse risk in that group of women. So now we know that by giving women with BRCA mutation this specialized medicine after their breast cancer treatment, we can reduce their risk for relapse of breast cancer dramatically. The third situation I want to mention is that with respect to HER2 overexpressing breast cancer. That's spelled H-E-R and then the number 2. HER2 is a gene that can be mutated in breast cancer cells, and that makes the cancer grow more rapidly. For years, this was known to be the case, that was a bad thing to see in a breast cancer cell, but we didn't know what to do about it. The scientists recognized that was a bad feature of breast cancer to have the HER2 protein or the HER2 gene overexpressed. So the scientists set about devising new treatments that work against the HER2 protein. And sure enough, we learned that when we treat a woman with that type of cancer with anti-HER2 medicine after their curative surgery and radiation, we can reduce their risk for relapse of their breast cancer. So I've tried to give 3 quick examples of research that's been done, which required clinical trials with women enrolling in them to show that in the case of the estrogen receptor expressing breast cancer, we can reduce relapse risk with a booster on their anti-estrogen medicine. With the BRCA associated breast cancer, we can reduce relapse risk with specific medicine that was designed to work against the BRCA mutation. And with HER2 overexpressing breast cancer, we can reduce relapse risk with a specific medicine that was designed to work against the HER2 protein. Again, these new findings, this new knowledge came about as a result of the willingness of women to participate in clinical trials where these treatments were tested and found to be successful. So just as Dr. James mentioned, being grateful to be practicing in the current era where we have had the benefits of these advances to help women stay well, I'm extremely grateful to have been around long enough to see these innovations happen in the treatment of all these different types of breast cancer, making it more likely that relapse won't happen and that women truly are cured when they complete their treatments with us. It is critical, however, as Dr. Halyard said at the beginning, that women get to us early enough in the process to allow us to get this success for them. Women who have their mammograms and who are doing their breast exams on schedule, to be able to discover a breast cancer when it first develops, and then they come into care with us, that gives them the opportunity for these cures that we so desperately want them to achieve. We have, representatives here on the panel today of that effect. Women who took charge of their health, who went to their doctors, went to their care providers when they recognized that there was a problem that needed to be addressed. They got the treatments that were required to achieve the cure that we promised them that they could have. And here they are today, experiencing cure of their breast cancer. And it's so gratifying to me and to all my colleagues that we've had the opportunity to participate in these processes for so many women who are deserving of this type of care. So again, breast cancer can be cured. And I hope that if no other message enters your mind today as you're listening to this presentation, you'll understand that breast cancer can be cured. It requires being proactive, being on the ball with your care, getting to the right doctors, getting to Dr. Halyard, Dr. James, who can contribute in a way that makes sure that the cure happens for you. Just as an example of what I'm talking about, we're going to hear from Panita Precher, who is such an inspiration to me because she's living the experience that we've just finished describing. Had her diagnosis, went through her treatment, achieved the cure, and is here today to provide testimony to that fact. So I'll stop talking now, Panita, and give you the floor.
Thank you. Thank you. First of all, I just want to say that I feel privileged and honored to be a part of this town hall. My intention is simply to share a piece of my story and experience with breast cancer, and that someone will glean something that will bring a sense of peace and hopefulness, whether it's surrounding your own diagnosis or someone close to you. So in July of 2019, like many women, I went for my routine mammogram. Came back as always, no problems, come back in a year for routine. But something went awry because 2 weeks later, I found a marble-sized round ball in my right armpit. And at the time, I really didn't think a lot about it because I just had a mammogram that cleared me. I thought maybe it was a hair bump. I ended up getting a biopsy. And 11 long days later, I found out the marble was carcinogenic. I was diagnosed with triple negative breast cancer. It was the right breast, and it had already metastasized to the lymph node. I went through 9 months of active treatment, including chemotherapy, surgery, radiation, and physical therapy for lymphedema in my right arm. So to say I felt disappointed about the diagnosis is an understatement. I was crushed. Certainly it ruptured my sense of self as I knew me. So the thing I learned about triple negative risk factors is that it's more common in people under age 50 and people with positive BRCA1, of which I did not fit that criteria. But I also found out that triple negative breast cancer is more likely to be diagnosed in African-American women and Hispanic women. So by virtue of my assigned race and born in America, I was at risk. This is the only criteria that I fit. Let's see if I can. So going through treatment, I journal daily. It helped me to keep records and track my symptoms and progress. I prayed, I said affirmations, I meditated. There were times I cried. And I was wearing a mask before it became chic with COVID. But early on, I learned about the Coalition of Blacks Against Breast Cancer, affectionately known as CBBC. It was a church member who just happened to be a supporter in the group. She texted me about this organization. I found the website and I looked at all the videos I could, probably in one sitting, because I was hungry for information. And it was so informative. In fact, I went to the next meeting and it was there in that conversation, I obtained information that helped me make an informed decision about what kind of surgery I would eventually undergo, which was a lumpectomy. So I've been with the group ever since, meeting by Zoom, thank God, because Zoom has made CBBC accessible to women outside of Arizona. And that's huge. I'm privileged to be a support for women who come into the group new to the journey. So I've said this once and I repeatedly say, I am so grateful to have found the best kept secret in Arizona, CBBC, when I needed it. So very quickly, let me share 3 things that surprised me as I traveled through this journey and still on it. Number 1, anybody can get cancer. My oncologist said, Panita, anybody can get cancer. I can get cancer. All the things that you've done is for the heart. So you see, part of my sense of self is being health-minded. Number 2, I learned that cancer can return to the breast area even if there's been a mastectomy. I'm like, what? I was hearing other people in my circle talk about getting a double mastectomy, even if the cancer was just in one breast, because they didn't want to deal with it anymore. I came to the meeting and learned, nope, not only can cancer return in that area, but a mastectomy is not a guarantee another kind of cancer won't show up someplace else. And then I thought, okay, maybe I need to change my diet. I thought I was health-minded, but maybe it'll be more preventive, right? And then I learned, nope, even a lifetime vegan can get cancer. So I concluded there's no panacea. In fact, in one Zoom group meeting, I was expressing my deep pain, and one of the doctors said to me, Panita, you did nothing to cause this cancer. And I still remember those words. They reverberate with me because those words lifted a burden. I was really trying to find out, what did I do? So ladies, I may be repeating it, but as a reminder, do your due diligence. Get your mammo as required, that's one layer. Do your monthly breast exams, that's another layer. And then seek medical concerns early. Be your own Harriet Tubman. You keep going back for yourself. So where I am today is I still do follow-ups with my oncologist every 3 months. There are other health challenges, but as someone recently told me, that's life. So what I rest in is all these things work towards my highest and my greatest good. So I just want to take this moment to say thank you for being a witness to my story as it continues to evolve.
Thank you, Panita, for sharing your story, for allowing us to be witness. Just a very powerful testimony for all of us. I didn't mention early on, am a breast cancer survivor of triple negative breast cancer also, and also went through 9 months of treatment. So very delighted to hear when Dr. James says the treatments, that radiation, we don't have to go through 37 bouts of radiation now. And just the progression of treatments and the research that's going on. And I just want to share very briefly before we get to questions that as a survivor, I have participated in 2 breast cancer studies. And I encourage so much that we as Black women get involved in the studies, because that's how we will be able to help change the disparities. Thank you very much, doctors, for the insight and the education that you've provided. We want to go to questions. I do see a question here in the chat. Give me just a moment to get it where I can see all of it. There's a question. When getting mammograms, is there a higher or lower sensitivity of the mammogram during the first week of a woman's period?
So since none of us are breast imagers, I asked that question to one of our breast imagers while we were talking. And so what she said was that there isn't that the mammogram sensitivity or ability to pick up disease in the breast really doesn't vary across the cycle. I know in the past there have been some studies that suggest maybe during that first week that it's better, but there really hasn't been proven to be a different sensitivity across a woman's menstrual cycle. Same thing with MRI, which is a test that sometimes we have to do in addition to mammograms to kind of look further into the breast. So it doesn't vary. Now, sensitivity in terms of pain or discomfort may vary depending on a person's menstrual cycle, the time that it's done. Sometimes if people are on their period, their breasts are more tender, but really being able to pick up the cancer really doesn't vary substantially across the cycle.
Thank you, Dr. Halyard.
Denise, can I make a quick comment, and then I have a question for Dr. James as well?
Absolutely.
I should have mentioned about the innovations in the treatment of triple negative breast cancer, especially in honor of the fact that you, Denise, and you, Panita, are here. But there has been tremendous advance in the treatment of triple negative breast cancer in the last few years as well. We learned through clinical trials that adding immunotherapy to conventional chemotherapy can reduce the chance of relapse of triple negative breast cancer. So what I'm referring to is the fact that there have been medicines developed that can switch on a person's immune system. and switch on the immune system in a way that the immune system helps fight the cancer. And that has been shown to be particularly effective in triple negative breast cancer. So now we know that when we see a woman who's had triple negative breast cancer, she's had her curative surgery and her curative radiation, we give chemotherapy and immunotherapy to her, and we can dramatically reduce the likelihood that her cancer will ever come back. So that's an innovation in the treatment of triple negative breast cancer that's occurred, I would say, in the last 3 or 4 years. That's really exciting because it's definitely improving the outcomes for women with triple negative breast cancer. I did want to ask Dr. James, I suspect this might be on the minds of some people who are listening. You always hear about radiation causing cancer, that radiation can be a cause of cancer. And yet you and Dr. Halyard use radiation every day in your practice to treat and help women with breast cancer. So can you explain the distinction there about how radiation is being utilized by you to treat breast cancer, but at the same time, there's this knowledge in the world that radiation can cause cancer?
It's an excellent question, and that is a question that gets posed to us from patients, and something that was on my mind before understanding radiation therapy as a treatment for cancer, because your whole life you're told that you should stay away from radiation, and radiation exposure is bad. But the way that it's utilized for cancer treatment is in a very controlled manner. So the majority of what we use are high energy X-rays, and it's just brief exposures to the target tissues for just short periods of time, and it creates DNA damage in tissue. Now, your normal body is able to repair that damage if you allow 6 to 8 hours. Cancer cells that could be remaining after a surgery cannot do that. That's why they are cancer. So it's a selective process, a way of treating microscopic disease after a cancer surgery. So very safe in the way that it's utilized now, and very sophisticated planning, very sophisticated treatment delivery systems that we have now. And as far as potential for having another cancer from radiation treatment, we call that second malignancies that can occur with radiation treatment and with chemotherapy treatment, but very low risk of that. So low lifetime risk of having another cancer from radiation exposure. Typically, something on the order of 1% or less lifetime risk, depending on the situation. And so the benefit that you receive from reducing your risk of cancer recurrence with radiation is far greater than any potential risk for secondary cancer from radiation treatment.
Thank you very much. I do have a question regarding reoccurrence. So I was diagnosed with triple negative breast cancer, more than 5 years ago, and was free of am free of triple negative breast cancer. In my most recent screening, though, a different cancer was found, and I'm glad to say that, again, early detection, early treatment, and it has been removed, and I am still cancer-free. But what I was really surprised about was that the second potential cancer was a whole different type of cancer than what I had the first time around. Can you speak to, how this happens, that it comes back, or it comes back differently, and what can be done to really safeguard myself and help others to make sure that we stay on a very healthy path and not potentially get cancer again, breast cancer again, same breast, different type of cancer.
I'm going to take the prerogative to try to answer this since I'm Denise's physician. I hope you don't mind, Denise. Denise's situation is a mystery, and I have to say there's still many mysteries in the cancer world. Why did Denise have a triple negative breast cancer more than 5 years ago, and then, within the last year had another condition in her breast, which thankfully was not a cancer. It was like a pre-cancer. But why does that happen? We're just not always able to understand why these things occur. It's more common to have something like that occur if you have a genetic predisposition to breast cancer, but we know Denise doesn't have that. So I don't want to be flippant about it by saying this, but I think it's just kind of a bad luck situation that this happens to people sometimes. Now, what's the silver lining here? The silver lining is Denise, like Panita, is on the ball. She is looking out for herself, and she is making sure that she has her follow-up mammography as scheduled, as everybody should. And, she's doing her self-exams. I know she is because we talk about it. And she's taking care of herself in other ways. She's managing emotional stress in her life. She's eating well. She's getting exercise. She's getting plenty of sleep. She's doing all the things that a person ought to do to stay well and to keep cancer at bay. So I give tremendous credit to Denise for how well she has taken on the challenge of taking care of herself and keeping cancer at bay. Why was this most recent episode with Denise not an actual cancer, but more like a pre-cancer? I think it's because she takes great care of herself. And I think she's a shining example, as is Panita, of how women can take charge of their lives, take charge of their health, and be the leader in keeping themselves well. So it's a tribute to Denise and Panita, and that's why they're here as representatives of that.
I agree with all of that, Dr. Northfelt, and including staying on top of your health, really being proactive. We do know that when a patient has breast conserving surgery, so they've had a lumpectomy and they have radiation, about the chances that something can regrow in that breast, regardless of how well you take care of yourself, is about 2% with all of the things that we typically give to people: surgery, radiation, sometimes hormone blockers or chemotherapy. That risk of what we call local recurrence or having breast cancer regrows about 2%. That's about the same as it is with a mastectomy. And Panita alluded to that when she talked about information that she learned at CBBC, because even though the breast is removed during a mastectomy, there can be some residual breast tissue that remains on the chest wall, particularly under the scar, or some perhaps microscopic cells that might remain that could have a recurrence. And so it's not like a person's personal failure if they don't if they don't come out unscathed without a recurrence. Just understand the risk of local recurrence is really low. And the more you do take care of yourself, the less chance overall that you'll have problems later on. But I don't want anybody out there who's had a local recurrence to feel like, oh, I didn't take good enough care of myself, so I had a recurrence. It just happens, and we don't necessarily know why it happens. And sometimes it's a different cancer, right? Biologically, it's a different cancer, or even a pre-cancer.
Thank you, Dr. Halyard and Dr. Northfelt. Again, we encourage the audience to give us questions, put them in chat or the QA function. And of course, I still have questions while we're waiting on other questions. When earlier in life, when I first started getting mammograms, I remember having an incident where the physician said I had calcification, right? This white image was showing up on the mammogram. And can you tell me a little bit about calcification and just how things look when we go for those mammograms and what's being looked at? It seems that I have lots of calcification in my breasts. And is there a relationship between calcification and then, developing cancer? I guess is my real question.
So I'll start, and then I'm sure Dr. James and Dr. Northfelt will fill in the things that I've forgotten to say. So when a radiologist is looking at your mammogram, they're looking at how does it look? Are there any densities in there that look abnormal? But sometimes patients can have calcifications, which are not cancer, but they're associated with the cancer cells or precancer cells that can tip the radiologist off that, oh, this is an area that needs to be explored further, whether additional imaging or whether it is related to needing a biopsy. And they look at particularly, are these calcifications new? You know, whenever people have had a mammogram in the past, we and the radiologists say, make sure that when you go and have your next mammogram, that if it's at a different center, that the radiologist has access to your prior imaging so that they can compare. So if they see new calcium spots or anything else, they know we need to investigate. There are also benign causes of breast cancer, or excuse me, benign causes of calcification. There's things called vascular calcifications where they look differently. And what the radiologist sees, the calcifications that we in the oncology arena pay a lot of attention to, is they look like little white salt grains on the film. Right, so that's what they're looking at. They look like you've dropped salt on there. That's the best way that I can describe it. It looks like. So the calcium isn't cancerous itself. It can be associated with invasive or pre-invasive cancer. Dr. Northfelt, Dr. James, anything to add?
Well, there are a lot of causes of calcification in the breast. Sometimes it's related to malignancy, as Dr. Halyard said, but there can be other reasons to have calcium in the breast. There can be calcium in the milk ducts that's just leftover milk from when the woman was nursing previously, because there's calcium in milk. So sometimes that hangs around in the ducts in the breast and the mammographer can see it. Sometimes there's calcium associated with blood vessels in the breast, because we all have, the potential to have some calcium deposit in the walls of our blood vessels. And if that happens to occur in a blood vessel in the breast, that's going to show up on a mammogram. There can also be calcifications that can occur if there's been injury to the breast, and then as part of the healing process from the injury, some calcification develops. The mammographers are magicians in their ability to discern the differences. So, while I might get a report on a patient's mammogram that says, well, there's a calcification in the blood vessels. Okay, well, they've seen calcifications, they've commented on them, but they've reassured me with the fact that it's not a malignant looking, it's not a cancer associated calcification they're seeing, it's just in the blood vessels. Okay, great. Or that they might refer to what they call milk of calcium, which is this situation where in the milk duct, some leftover milk has persisted and you see the calcification from that. So the mammographers are usually very adept at being able to identify whether it's a good calcification or a bad calcification. And I think that's something that patients often need to have explained so that they can feel reassured.
Thank you both for the clarification regarding calcification. We do have a few questions now in chat. One is it true that breastfeeding decreases the risk of breast cancer?
So yes, it goes into consideration of what we call high estrogen states. So some of the risk factors associated with breast cancer is not having children or not having the opportunity to breastfeed. And it's just definitely having that opportunity to do breastfeeding does not increase your risk, at least, and there is some evidence that it might decrease it as well.
Thank you, Dr. James. The next question, if a woman has dense breast tissue, is an ultrasound better to pursue than a diagnostic mammogram?
You always want to have a mammogram. You always want to have a mammogram. Mammogram is the only way to see these calcifications that Denise brought up earlier. So if you have only an ultrasound, the calcifications won't be seen, and that could prevent you from having a very important clue that there's cancer there. The other thing about ultrasounds is it's very what we call operator dependent. I mean, it's in the eye of the beholder. The mammographer or the technician scanning the breast may do it quickly or slowly or carefully or maybe not so carefully. And that can affect what we can learn from the ultrasound. So it is not the best test. The questioner says, is it better to pursue a diagnostic mammogram? And my answer to that is that's really the gold standard. Because when your provider orders a diagnostic mammogram, that means you're going to go there, have your mammogram, and then if necessary, an ultrasound as well. But the key thing about diagnostic mammogram is that more time is scheduled for you at the facility so that you don't leave until there's an answer. With screening mammogram, it's like a conveyor belt. You go in, you get your picture taken, and you leave, and 2 weeks later you get the result. That leads, to fast flow of patients through the facility, but it doesn't allow the time that often is needed to look at something that might be more complex. So when I have a patient where I feel like more time is required and more thought and care has to be put into obtaining their imaging, I'll order a diagnostic mammogram, because then I know that they will be kept at the facility and all the necessary pictures are going to be taken before a conclusion is reached. We also have other strategies for women, say with dense breast tissue, where we might order what's called a contrast enhanced mammogram, or we might order an MR scan. Those are techniques that are used when the breast tissue is dense, and that can often obscure what we're trying to see. So we have these other strategies for that specific situation.
So it's beyond the scope of this panel to talk about the difference between a screening mammogram and a diagnostic mammogram, but we had an excellent discussion this past weekend at our Coalition of Blacks Against Breast Cancer educational portion that will be posted to our website, cbbcaz.org, that will be posted within the week. So I invite you to go and view that video, because it really talks about the difference between a diagnostic and a screening mammogram, which is important to understand.
You're muted, Denise.
Thank you. Can someone speak to the higher risk of first-line offspring of prostate or breast cancer parents, increasing the chance of breast or prostate cancer of their offspring?
Maybe I'll try to quickly answer that. We know that predisposition to breast and prostate cancer travel together in families often. So if there's a parent who had prostate cancer or breast cancer, and then we're seeing the offspring of those parents, we look at them as potentially having a genetic predisposition. What we would usually do in that circumstance is send that patient to our genetic counselor for a more thorough investigation of their family history, and perhaps for some genetic testing, which is done via a blood test, to learn if they have a genetic predisposition to breast and prostate cancer that's running in their family. When we know that somebody has a genetic predisposition to cancer, we do extra things to try to keep them safe. We do more frequent breast imaging. We do more frequent testing looking for early signs of prostate cancer and so forth. So understanding that cancer runs in a family, and then identifying a genetic predisposition to cancer through genetic counseling and testing, that gives us an opportunity to be really helpful to that entire family in terms of keeping them safe.
And then just to piggyback on what Dr. Northfelt was just explaining, it highlights the importance of discussing health in general, but specifically cancer diagnosis amongst your family to really try to take that time to have those conversations so that you're aware of what is in your family and so that you know how to be more proactive about your health care and cancer screening.
Wonderful, wonderful. And just want to know if there are any other closing remarks as our time is about up. We have just a couple minutes.
There is one additional question in the Q&A. So I can read it. It says, do you know if Mayo requires a physician script or an order to get a mammogram? In other words, may a patient self-schedule without this as at some medical centers? Thank you.
Thank you, Dr. James.
Dr. Northfelt, can you answer that question?
I don't believe that you can get a mammogram at Mayo without a physician or a provider's order. The reason for that is that if the mammographer sees something, they want to be able to call the provider who can move the patient along to whatever is needed next. So if a mammogram is done and a mass is seen or calcifications are seen, the mammographer wants to call a doctor or a nurse practitioner and say, hey, your patient needs more help. And if there's no provider, then the mammographer doesn't know who to call. So at Mayo Clinic, there's always a provider connected in the process because I want to know if my patient has an abnormal mammogram so I can do something to help her.
Thank you so very much, panel. It has been just very enlightening and inspiring, the conversation today. And we look forward to another town hall soon.
And if you do need us, we have the Coalition of Blacks Against Breast Cancer. Our website is cbbcaz.org. We also have started a prostate cancer group, the Coalition of Blacks Against Prostate Cancer, and we're under the umbrella of Coalition of Blacks Against Cancer. So please reach out, let us help you. We have a support group 3 to 5 p.m. third Sunday of every month, both hybrid in person and on Zoom. So we look forward to seeing you.
Look at the videos. Look at the videos.
Take care, everyone. Thank you.
Bye-bye.